Welcome everyone to the Aspire's web series, The Troubleshooters in ART. Today we are going to discuss the oocyte and embryo freezing and thawing, how to improve success and minimize failure. I'm Arthur Chang, and I will be the moderator for today's section. We have three outstanding speakers to discuss how to improve and also minimize the failures. But with the development of vitrification techniques, cryopreservation has been applied in fertility preservation and ART, and its use has progressively increased worldwide in the last 2 decades. Accordingly, quality management of cryopreservation in embryology labs should be more focused than ever. The cryo outcomes, such as survival, development, and pregnancy rates, can be affected not only by intrinsic factors, but also extrinsic factors, including the vitrification, warming solutions, protocol, practitioner, and add-on procedures. In this section, experts will discuss how to minimize the effects of extrinsic factors to maximize the cryo outcomes. The following topics will be covered. First, the concept of cryopreservation, the main methods utilized currently throughout worldwide, and the criteria. Second, the quality management, including troubleshooting. Third, add-on procedures. We will also discuss recent developments in cryopreservation techniques. And last but not least, the staff training and evaluation, which has been very critical in the cryo outcome success. The participants will be provided with introductions on selecting the cryopreservation method, the importance of adhering to the protocol, troubleshooting when cryopreserved oocytes and embryos have degenerated, as well as tricks and tips to improve the outcomes. I would like to introduce today's speakers. We have Dr. Kenji Ezoi. Kenji is a senior scientist at the R&D laboratory of the Kato Ladies Clinic in Tokyo, Japan. He obtained his PhD degree in agriculture from the Tokyo University of Agriculture and Technology. His research interests include fertilization, embryology, cryopreservation, and Brussels cyst implantation. Dr. Sui-Lian Liao. Dr. Sui-Lian Liao is the scientific director of the Virtus Fertility Center, Virtus Health Singapore, a member of the Virtus Health Group in Asia Pacific region. Dr. Liao was involved actively in the training of postgraduate students in Master of Clinical Embryology at the National University of Singapore. He also set up 3 IVF centers in Singapore. He obtained his professional qualification and training both local and overseas from the Whitesell Research Institute, Wisconsin, USA, for human embryonic stem cell culture methods, and pre-implantation genetic diagnosis from the University College London, UK, laser micromanipulation from University of Heidelberg, Germany. And Dr. Liao has vast research experience and is one of the pioneers in micromanipulation techniques like ICSI, IMSI, polarized light microscopy, which also known as oocyte, and laser-assisted hatching, as well as laser micromanipulation techniques. Our third speaker is Ms. Adele Lim. Ms. Lim obtained her master's degree in clinical embryology from the University of Leeds, UK. She is now the scientific director of Alpha IVF Group Berhad in Malaysia. She is responsible to oversee the operational and administrative management of Alpha IVF Group's labs. She involves in research activities, managing embryologists and geneticists, overseeing the QC of labs and the laboratory expansion activities. Throughout her strategic planning and resource management, Ms. Lim ensures the lab's operations are streamlined and effective, facilitating advancements in research and development while also meeting the needs and expectations of stakeholders. Her main research works are in the areas of ART, focusing on artificial intelligence, regenerative medicine, PRP, salvaging technologies, sperm sorting, embryo selection, and genomics. She has authored and co-authored over 106 publications in peer reviews and conference abstracts. I would like to thank all three outstanding speakers to bring in their experience and insights into today's web series. So first, I would like to ask the experts on the rationale and concept of the cryopreservation from slow freeze to vitrification, because all of our three speakers has experience, probably, as I mentioned, will probably belong to the like a mid-age or kind of like a senior age like groups. We have seen the slow freeze from the beginning of the development of the technology and throughout the vitrification and some like interesting techniques. So first, I would like to probably Sweden and me, we are the kind of like the older generations. I would like to ask Sweden, how about the old days of the slow freeze and the vitrification? Like, I don't know how many of us are still doing slow freeze. Occasionally, we still have some patients. They actually was frozen with the slow freeze method. We have to use those warming techniques. We have to order spatial medium, or sometimes we have to follow their protocol to do those like homemade ones. Yeah, I would like to ask Suilin, like when you have those cases, and how do you handle them?
Well, okay. Currently now we don't have any more, but a few years ago, about close to about 8 to 10 years ago, we had some of these embryos that have been frozen embryos. So what we need to do is that in most of these embryos were imported from other IVF clinics to us. So what we do is that we need to get from probably the supplier. We ask them, okay, what type of slow freezing medium that they use, and try to get this quite similar product from the thawing solution, and then from there we just thaw the embryo. But if we can't, then we will try to modify it, where maybe, since we have some vitrification medium, so we try to modify it and see how well it works. But usually, most of the time it works, and embryo does survive. And because these embryos were frozen at cleavage stage, day 2 or day 3, so they're quite hardy in that sense. Yeah. And
yes.
And slow freezing, of course, there's a disadvantage in the sense that when during the bringing down after the equilibrium and everything, when you bring it down to the storage part to minus 196 from the room temperature, it takes about 1 hour to 1.5 hours to reach that. So whatever there is water retained in the embryos has become ice, and that could have caused the lower the success rate of our survival rate after thawing of the embryo. So it's very critical that the freezing successful survival for slow frozen embryos usually about 50% or 60%, or you sometimes you will see, let's say for 8-cell embryo, sometimes you can see 1 or 2 or even 3 blastomeres has been lysed after thawing. Yeah, this is quite common in slow frozen embryos.
Mm-hmm. Yes, yeah, I still remember that. Yeah, when we used to do the slow freeze, we have to do the seeding process, and sometimes we have to redo that if it failed. And yeah, but once the seeding is successful, then we can go to a cup of coffee and come back about like 2 hours later. Yeah, yeah,
Exactly. When the spec, particularly, let's say we need to freeze at 4 p.m. or 5 p.m. Oh boy, when they go reach home by leave about 7 p.m. from work, so it's a bit late sometimes. Yeah.
yes, yeah. And how about Dale and Kenji, like in Malaysia and also in Japan? So do you have to handle some of the specimens coming from slow freeze, especially if you don't do that anymore, but maybe your patient has some specimens transferred from external clinics?
For recent 20 years, so we haven't experienced a transfer of slow freezed embryos. Yeah.
So do you reject those if
Not
your
reject,
patients if they have some like older specimens, they want to come in and use them? Do you reject those?
Not reject, maybe accept, but recently, so vitrification is a major cryopreservation method in Japan, and it's very rare. Yeah.
Yeah. Dale, how about in Malaysia? Have you experience that have to handle those specimens now?
Yes, it's very rare now, but we accepted before from embryos frozen using slow freeze. We tried using the vitrification thawing method to thaw those slow freeze embryo, and we get them all survive actually. So in fact, we do not really need to use a different type of media. We can just use back the thawing media that we usually use in our labs to thaw the slow freeze embryos.
Mm.
Yeah, it does work now. Yeah,
Yeah,
we,
it
we have
does work.
tried,
Yeah.
we try 1 or 2 cases like that because nowadays you can't find any
Yeah.
slow frozen thaw medium, to thaw the embryos anymore. Yeah.
Yeah.
Yeah, a lot of companies they have discontinued those like a warming media, and we've been told that you can use a vitrification warming just for those slow freeze.
But honestly, I haven't tried thawing the vitrification thawing media on frozen oocyte before. The oocyte that is freeze using slow freezing. I haven't tried that before. The ones that we accepted are usually day 3 embryos using slow freezing.
Yeah, yeah. So for those like cleavage stage embryos, would you culture them through blastocyst or would you just thaw and transfer?
Usually we will culture them to blastocysts. Those cases that usually transferred to our center for PGT testing. So we usually will culture them up to blastocyst stage. Those that make it to blastocyst, we will then biopsy and do PGT. And then we freeze them at blastocyst stage.
Yeah.
So what we do over here is that let's say if we have these embryos or cleavage stage embryos, and of course the patient will have come for 1 cycle and new cycle, and we have frozen the embryos at blastocyst stage in vitrification. So when they have the cleavage stage embryos, we will advise them, we will thaw them and then grow them to blastocysts. If they survive, then we will transfer them. If not, then we use the freshly vitrified embryos for transfer. Yeah.
Now, Kenji, how about your standard practice? Do you culture them or transfer?
Yeah, usually we transfer the cleavage stage embryos on day 2, but our main strategy is blastocyst cryopreservation. So if we got, for example, so 3 or 4 embryos, we vitrify 1 embryo on day 2, and rest of embryos are cultured to the blastocyst stage and cryopreserved at the blastocyst stage. And so we prioritize to transfer blastocyst first.
We got our first questions here from Amar Ali. Amar asked, so we can use the vitrification warming medium for thawing of slow frozen embryos or oocytes? So that that's a question. So I think we touched a little bit about that. So I would like to ask all three speakers their opinions, just using the vitrification warming media to store the slow frozen embryos or oocytes.
I think like Adele has said, we only experienced to thaw using the vitrification warm medium to warm up to thaw the frozen slow frozen embryos. Oocytes, no, we have not come across any of those yet. But I think maybe the oocytes may be more tricky to thaw, maybe because it's on a single cell, one large cell, then it is the risk of damaging it is higher compared with the cleavage stage embryos. Yeah. Adele, what's your opinion, Adele?
Yeah, we haven't experienced on slow freeze oocyte before, but probably you can check with your vitrification warming manufacturer whether you can use the same method on thawing the slow freeze oocyte, or maybe they can advise you on a modified technique. Probably, I'm not sure. Yeah, but we never experienced before using vitrification warm media on oocytes. That is slow freeze. Yeah.
So Kenji, do you use like a homemade solution to
No,
flow those?
we buy commercial based solutions.
I see. Yeah. I think that's pretty much the consensus nowadays. So let's talk about the cryopreservation criteria in each of your center. Like when you have a patient, some of them have good prognosis, some of them probably don't progress that well. How do you decide which? Let's talk about embryo first, and then oocyte later. So how do you decide which embryos they are determined to be vitrified, and which one you will just pass or discard? Kenji?
Okay, so as I said, we cryopreserved the vitrified cleavage stage embryos and blastocyst. And for the cleavage stage embryos, so we vitrified embryos on day 2. And if the cell number is more than 3 in the morning of day 2, we vitrify these embryos. And for the blastocyst, we vitrify them on day 4 to day 7. And if the blastocyst diameter is more than 160 micrometer, we vitrify them. So we based on the blastocyst diameter, not morphology. Yeah.
Oh, the diameters. Oh,
yes.
Yeah, that's very. I think most labs probably don't use that criteria. So you use diameter also.
Yes.
Yeah. Adele? What's your criteria?
In our lab, we almost doing blastocyst culture, almost 100%. So even if we need to freeze the cleavage stage embryo, we usually freeze them on day 3. So we rarely will freeze them on day 2. So we will usually freeze them on day 3. And then for blastocysts, we don't measure the diameter. We freeze them if, let's say, the blastocyst has already have a well-defined ICM and trophectoderm cells. So we usually freeze embryo with grade fair and above using Gardner's grading. Yeah.
Like what we do here is that we always grow the embryos to the blastocysts, and all depends on the number of blastocysts available for freezing on that day. Let's say if this patient has about 7 or 8 blastocysts, day 5 or day 6, and then we will be quite strict on the selection process. So let's say if one of the blastocysts, the day 6 has a CC grade, or CC, definitely we will not freeze. But if it is a 5 BC, but the rest are all BB and BA or AA, then this BC will not be frozen. But if in that case, if the situation arises where the patient has only 1 or 2 blastocysts, and the quality is BC, we will usually freeze them. Yeah, that's the criteria because for us, because our protocol is all on FET, frozen embryo transfer. So the patient will transfer only a single blastocyst, and usually with those, once the patient has been successful, build up their family size, those remaining embryos they usually will discard. So usually for those members who have more blastocysts, then we are really strict on selecting the blastocysts for transfer. For freezing. Yeah.
Those are very excellent points.
Mm.
So how about the oocytes? Like I would like to ask the speakers like how they choose the oocyte to vitrify, and also the follow-up questions is for the immature ones. For example, like M1 and the GV, would you wait to freeze, or would you freeze some of, for example, like M1, then you store and wait for them to mature? So criteria of freezing oocytes, as well as how to handle the immature oocytes. Sweden, I will start with you.
Okay.
Yes.
Okay. Now, to me, quality is very important. So let's say, even let's say the woman has 20 eggs collected, and out of that 16 mature, or even 20 and metaphase 2. As long as the eggs do not have any intracellular defects like SER or some vacuoles, then we will freeze those. But if we come across one or two that having SER or vacuoles, then we will not freeze them, because usually those eggs that the embryos that derive from SERs usually are aneuploid, and even let's say the patient managed to have implantation, usually miscarriage rate is very high in those eggs come from the SER. But in situation whereby the woman that comes in have very low AMH, where we could collect only 1 or 2 eggs or 2 eggs, and unfortunately, one of them is mature, the other one not mature, we will do an IVF, and then next day, if it reaches metaphase 2, then we will freeze them. So it's all based on case-by-case basis.
Adele?
In our lab, we freeze only M2 oocytes. So for those that like GVs and M1 on day 0, we usually will culture them to day 1. So we assess again on day 1. If let's say they become M2, then we freeze those M2s. Yeah. So, and also if let's say, usually we will freeze all M2s, depending. But of course, we would assess their quality first. Those that on, like, for example, a large oocyte with SER, we will make a note. We note down, and then, but we still freeze them. Yeah.
Like in our situation, we always, before, let's say, for coming for social egg freezing, the patient will have been counseled, and then we always highlight to them what are the quality of the eggs that we're going to freeze, what we're not going to freeze. So at least they are aware what type of eggs are you freezing. Yeah.
Kenji, how about the criteria in your center?
Yes, our criteria is similar to adults. Yeah, so we vitrify only mature oocyte, M2 stage oocyte, and then if we got the immature oocytes, so ZB or M1, we culture them to the M2 stage, and if we confirm the first polar body extrusion, so we vitrify them. So we culture until the next day morning.
Yes. So we got 8 questions. So I'm going to pick up some of the kind of more relevant to the current topics now, and some of the others later though. So there's a question about like some units freeze at the PN stage on the embryos. So has any of you doing that nowadays? Like a PN stage freeze? No. Yeah.
No.
I think it's kind of rare though. Yeah.
Yeah.
I know some centers they want to kind of to have some, if they have a lot of like oocytes they fertilize, then they have a lot of zygotes. They want to be safe because sometimes the culture system might not be stable. Yeah, I think in the old days there were more people breeding that PN, but I don't see many centers doing that. And also for Kenji,
Yes.
how is the diameter of the hatching blastocyst considered? For example, in the case of PGT.
So same as cryopreservation criteria. So if we confirm blastocyst lead to larger than 106 micrometer, we had the blastocyst using laser system and perform biopsy.
Okay, so if the blastocyst is hatching, then their diameter has to be like larger than your criteria,
Yes.
right?
Yes.
If occasionally you see those small, like a small size blastocysts, however, they kind of like hatching out. Do you do assist hatching on day 3 or until you do biopsy?
So just before biopsy.
Okay, so most of them, if they already like a self hatching out, they are probably good size, right?
Yes.
In diameter. I see. Yeah. There's a question about could you freeze the blastocyst with grade 4 BC and 5 BC? Also, do you collapse the blastocyst before freezing with laser? I would like to ask all 3 speakers to share their experience.
Let me answer this one first. Yes, we do freeze embryos at 4 BC or 5 BC, as I mentioned earlier, depending on the number of blastocysts available for the patient. If the patient has many blastocysts to be frozen, then we are more selective in the quality. And if 1 or 2 have 5 BC or 4 BC, we will not want to freeze that. But if the patient has only a very few blastocysts, maybe less than 5 or 5, then we will freeze them. For freezing of the blastocysts, we always use a laser to collapse the blastocysts prior to freezing. Yeah, and in fact it helps in the improve the survival rate of after warming of the blastocysts. That is from our experience.
The collapsing the embryos.
Yeah, laser. Yeah.
Mm-hmm. Yeah.
So
Adele, your experience?
We don't collapse blastocysts before freezing, but most of our cases in our center, I think about 80% of the cases are for PGT. So usually we will biopsy the blastocysts and then proceed for freezing. So those that is not for PGT, we usually just freeze at ease. We don't collapse them. Yeah.
Yeah. But they technically they are collapsing already, right? After you biopsy them.
Yeah.
Kind of. Yeah. But for the rest, like 20%, you just
we don't
collapse them. Okay.
But sometimes Can you?
Okay, so thank you. So in your clinic, we vitrify the blastocyst with grade 4 BC, 5 BC. Yeah. So our criteria is based on blastocyst diameter, not the morphology. And as for the artificial crops, so we artificially shrink the blastocyst before vitrification with hypertonic solution. So we dilute the DS solution, dilution solution with washing solution 1 by 1, and we prepare 0.25 molar sucrose solutions. And using this solution, we shrink the blastocyst before vitrification.
let's say one question for Adele is that, let's say if you don't do collapsing of the blastocyst before vitrification, uh, sometimes this embryo may not shrink completely, collapse, maybe partially. It takes longer time, 10 minutes to 15 minutes in that solution. What are you going to do? Are we going to continue doing the freeze after that? Would freeze the embryos or wait it longer for it to collapse?
We usually will wait until a maximum of 15 minutes. Usually, if we will not pass the 15 minutes, even if we don't expand back, that's the max. 15 minutes is our max.
So, do you see any? What about the survival rate of these embryos after warming? Let's say
Survival rate
compared with those that you have done the PGT, of course, collapsed, and those that have not collapsed.
usually for PGT, by the time we finish PGT or the biopsy, almost like 2 to 3 hours after that. So when we start to do freezing on those blastocysts, actually they already expanded back. Yeah, so usually we usually don't collapse. Just freeze at this. Yeah. So far we have good survival rate. Usually those that we thaw out, usually they will expand back nicely before transfer. Yeah.
I'm just asking about the one that you have not, those I have not done, not PGT, no embryo biopsy done, but is partially shrinking, and you vitrified them. Then what's the survival rate of those embryos that have been warmed?
They still survive nicely. Yeah,
Okay.
all intact cells. Yeah.
So how about Soylin and Kenji, your experience about those?
Usually for us now, we always do the collapse using laser. So the survival rate is very, very good. In fact, almost 100%, like 9.9% survival rate of those embryos. But from our previous experience before we did the collapse, and those embryos that are partially shrinking, we will see some of these embryos did not survive after warming. Yeah, probably because the freezing was not done properly, or some ice formed inside, and that's why it caused the embryo to lyse after warming. But that is very, very rare. Yeah, but not every time. Yeah, that this embryo will not survive. Like what Adele say, majority of the embryos will survive without collapsing the embryo.
Yeah.
Yeah, in your clinic, we artificially shrink all blastocysts before vitrification, and our previous experimental study demonstrated that if we perform artificial shrinkage before vitrification, so this procedure improves the survival rate after warming, and also implantation, so adhesion competence to the fibronectin coated dishes, and the trophoblast migration is better when we perform artificial shrinkage. So especially when blastocyst diameter is more than 180 micrometer. So so according to this result, we perform artificial shrinkage before vitrification.
Dr. Kenji, can I ask, comparing both method for artificial shrinkage, laser, and also the one that you are using, which one is better?
So we have compared the blastocyst outgrowth outcomes, and there are no significant difference. But if we use laser systems, we need to move culture dish from stereo microscope to inverted microscope. So there is some risk for the dish. So because of this, we use a hypertonic solution to shrink blastocysts under the stereo microscope.
Okay.
There's a question kind of related to what we just discussed. So should we freeze the M1 oocytes after thawing and culture 2 to 3 hours for like a maturation, or just the culture the maturation and move to another day before freezing? I think that probably mean that you want to freeze M1 and thaw, then culture for maturation, or like wait for another day, then freeze them though. So is there any significant advantage of one method over the other one? Adele, what's your opinion?
We never try freezing M1 oocyte and then thaw it out and culture 2 to 3 hours for maturation. We will usually wait for until day 1 and then check again in the morning. If there's M2, we freeze again. So we are actually doing a lot of salvaging technology, especially for patients with low number of eggs. So we even do it on fresh cycle, fresh eggs. If let's say the patient only have a few M2 or few eggs and we inject the M2 on day 0, and then we actually culture them to day 1, and then we inject the remaining eggs that became M2. So we actually have, we published our study that we actually have live birth deriving from delay XC eggs. Yeah.
So then,
Usually what we do is that what Adele said is that if we encounter M1 egg on a day 0 before we usually don't freeze it. What we do is that we do in vitro maturation the next day, and if this M1 has become M2, then we will freeze that egg. Yeah, and as I said, that depends on the number of eggs collected from the patient. So if the patient has very, very few eggs, then we will do this IBM thing. If the patient has many eggs, let's say 20 eggs, 20 M2, so and you only have 1 or 2 immature ones, we will not freeze those or do IBM on them also.
so you would do the IBM after you thaw the embryos, right?
No, before.
No, before.
No, before.
Before.
Okay. So
Before.
have you tried like a thawing and do IBM?
No, we don't thaw and do IBM. It may
I see.
it may damage the egg also. Sometimes all these things, you don't know what's happening inside the M1 stage internally, the egg itself. Yeah.
Mm-hmm. Yeah. Kenji, do you
Yes.
do like IBM as well?
Yes, so we don't have experience of M1 oocyte vitrification, so we usually culture these oocyte and then vitrify them. So after confirmation of maturation. So yeah.
Let me see. We have a good amount of the questions. I'm trying to pull some of the relevant one. Oh, here's one question. Do you think that the oocyte freezing procedure can affect the meiotic spindle and then negatively affect the chromosomes of created embryos? I think Kenji, you guys look into that before, right? Yeah.
Yes, of course, freezing procedure, the vitrification procedure affects the spindle, meiotic spindles. And after vitrification, we cannot detect the spindle. That's just after warming. But after culturing, so 1 hour culture or 2 hour culture, we can confirm the presence of spindle. So this is because of the vitrification adversely affects the microtubule polymerization. But this is not detrimental effect. So, and yeah, so if we culture the oocyte more than 3 hours after warming, they can recover the spindle and developmental competence. But so I'm not sure. So we don't have data about the chromosomal segregation or chromosomal status. So, but they can develop to the blastocyst stage if we culture the oocyte 3 hours after warming.
Thank you, Kenji. For Sweden, you
Yeah,
mentioned the IVM. Yes.
Okay,
Yeah, go ahead.
so regarding the meiotic spindle thing, yeah, usually I think it depends on because for freezing for vitrification of the oocyte is very tricky. Because let's say if you normally what we do is that 2 hours after egg collection we will process the eggs for freezing. Apparently, you cannot try not to delay 4 hours after or 5 hours. The longer you delay after OPU, the survival rate or the quality of egg degraded. So usually what we do is our practice is 2 hours after OPU, we process the oocytes and then do the freezing immediately. Now, as for the appearance of the meiotic spindle, yes, freezing may harm the spindle as what Kenji said, depolymerize the basic spindle. But after warming, what we do is that we allow about 1 or 2 hours after warming before we fertilize the vitrified eggs. Because we do a lot of those donor eggs that are imported from banks overseas, and I always evaluate the oocyte meiotic spindle using the polarized microscopy to look at how good this meiotic spindle is. So most of the time, the meiotic spindle are still intact, but of course you will find some that are damaged. You can't even find a meiotic spindle after 3 or 4 hours after warming. But that is quite rare. But usually the meiotic spindle will polymerize, and the blastocysts will generated from these eggs with meiotic spindle, good ones usually give a good blastocyst rate. But those eggs that are the meiotic spindle that are a bit defective or usually will not reach to blastocyst stage, and fragmentation is high. Yeah. And patient does have live birth when we transfer.
So Sweden, do you do the spindle check before freezing those oocytes? Is that
we don't do spindle check before freezing. We only do spindle check after we warm the oocyte before at the time of fertilization, at the time of ICSI.
Yeah. Mateo and Kenji, do you check the spindle before freezing them?
No. Well, we
No.
used to. Sorry.
Sorry. Go ahead, Dr. Kenji. Go ahead.
Go ahead.
Yeah, we don't check spindle before freezing as well. So, pretty much our practice in Malaysia is almost similar to Dr. Liao. Also, we wait about 2 hours, then we freeze, and then after thawing, we also wait about 2 hours before ICSI. Yeah.
Kenji, your turn to answer.
Same as both of you. So we don't check the spindle before vitrification, and so just after warming, so we check the presence of spindle.
I think if we check spindle before freezing, it will be very costly to the patient, right, Dr. Liao?
Well, I mean, but for me, we are altruistic. We don't have any extra charge. We are more for curiosity. We just look at them. That's all.
Yeah. And here are two kind of related questions I would like to ask Dr. Liao. So for the IVM, do you have any special medium, and also do you add any additional agents in the medium to culture those M1 or GVO site?
Okay, that is a very practical question. Usually what we do is that after egg retrieval, usually we will assess the looking at the COC and everything, and when we look at it, whether the COC is sparse or whether it's tight, and looking at all those things, then we will, like let's say the corona is very tight, we know that definitely it's immature. We will not denude it. We just straight away put into IVM. Because these cumulate cells or corona cells, they are the ones that are important for giving maturation factors to the egg and feeding nutrients on that side. So for us, there's no special medium for IVM. I use the cumulate cells to do IVM for the eggs without removing any of them. Because if you remove them prematurely, they may reach the beta phase 2, but the quality is not as good as if you don't remove them at all for IVM. Yeah.
Mm. So for those like IVM, so you don't suggest like complete denuding, right?
Yeah, we don't. Yeah, and we for us we use vitrified medium. So I usually use the what do you call it, GFER, GFER plus, because it's very rich in calcium and other nutrients in that for IVM. I don't use G1 medium for IVM.
Mm. Yeah. Here's another question I would like to ask Ms. Lim and Dr. Ezoy. So this is for the standard practice, which probably the M2 oocytes. Should we completely denude or partially denude the oocytes before freezing? Because the granulosa cells have a kind of nutritious role for the oocytes, and also the question also asks, if we partially denude the oocytes, does this affect the survival rate after thaw? Adele,
We
what's your
don't we
experience?
usually completely denude the eggs before freezing. We don't partially denude. Yeah.
Yeah, me too. So we completely remove the cumulus cells before vitrification.
I think the reason why we remove completely is because of the rate of freezing. Because if you have cells there surrounding the egg, that affect the rate of freezing of the egg, probably slow down the rate of freezing, and then maybe that helps in maybe ice crystallization later on, and then survival rate of the oocyte after warming may be affected. Is that right, Kenji?
Yes.
Yeah.
So let's jump to the embryo, freezing and thawing. And there are actually two questions kind of related. So for the CC grade embryo, the Brussels cyst, as well as the day 7. So what would be your suggestions on freezing the CC grade Brussels cyst, as well as the day 7 and their survival rate and success rates? Kenji, I'll go with you first.
Yes, so for CC grade Brussels cyst and the day 7 Brussels cyst, we perform vitrification using the same protocol. And so we artificially shrink these Brussels cysts and vitrify using the same protocol. Yeah, of course, survival rate is a little bit lower in day 7 Brussels cyst and CC Brussels cyst, but in our clinic, survival rate of these Brussels cysts is higher than 99%. So I think we don't need special protocol for these Brussels cysts.
Dale, do you feel the CC grade Brussels cyst and also the day 7? Do you freeze those embryos as well?
We will usually, for those CC that is on day 5, day 6, we usually will push them to day 7. But if let's say they still remain CC on day 7, we don't freeze CC grades blastocysts. Yeah. Because like I mentioned before, we do a lot of PGT because CC doesn't qualify for us to do biopsy. Not enough cell for us to biopsy. So usually we would not freeze those blastocysts.
I see. And
usually for us, if it's a CC grade, we usually don't freeze. Either it's day 5 or day 6 CC grade. But if let's say if the patient requests that we freeze those CC grade, then we will freeze it. But we will always counsel them that the chance of survival is not as good as what you have a better quality embryo, and also if it's a CC grade, usually the embryo implantation is very much lower. It may not implant most of the time. And if it's a day 7 embryo, you see why the embryo takes 7 days to reach blastocyst. Probably by then they have a lot of errors. It probably is a high risk of aneuploidy. And if you were to transfer this, most of the time implantation may happen very low, but usually high risk of miscarriage. Of course, there are some cases of live birth being born, but that is very, very, very little, very, very low. To me, we don't freeze CC grade or day 7 embryo, most of unless the patient requests.
Thank you. And so this is a question for Adele, because Adele, you have done some research in the artificial intelligence. So as a automated vitrification, is that superior? And also another follow-up is how does the AI apply to the vitrification and thawing? Is there any concept on that?
You mean using automation in freezing and thawing?
Yeah, the vitrification. Yeah.
Yeah, I have no experience before using automation in vitrification and warming. The AI that I'm working with usually on embryo AI and also endometrial AI. Yeah.
And how about the refreezing?
Yes, we do.
Does any of you do? Yeah.
Yeah.
For PGT and culture for blast, right?
Yeah. For frozen blastocysts that is usually transferred in for PGT, we will not do a fresh transfer. We usually will thaw them and then do a biopsy and then refreeze them. So after the PGT result is out and we know which is the normal euploid, then we will thaw them again and transfer to the patient. Usually the success rate or the survival rate are quite similar.
I'll go to another question here. We have a good lineup of questions and we have limited time left. So we'll try to work on those questions as much as we can. So for Kenji, here's a question. If the oocyte or embryo, if they don't survive the stall, so what would be can you tell the problem of freezing, thawing, or sample quality? What would be the kind of like the most common issues you will start looking into?
Yes, so we sometimes face oocyte degeneration after warming, and in these cases, we have to speculate the possible causes of degeneration by observing the degenerated oocyte in details. And if we can see the cell membrane damage, there are two possible causes. So ice crystal formation and over rehydration. And so for the first thing, we have to check we have to check several steps. For example, so whether the CPA exchange was sufficient during BS step, or whether the volume of BS on the seed was optimal, or whether TS TS temperature was optimal. Yeah, we have to check this. And also during warming process, so we check, so we move the oocyte with excess solution. So from TS to DS and DS to WS, so we have to check it. And also we sometimes see the incomplete recovery. So first, there are also two possible causes. And so first one is physical pressure. So if the volume of a BS on the cryotop is too small, the physical pressure can cause damage on the cytoskeleton. And the second is embryo drying. So embryo drying on cryotop, cryo device, can lead to cellular damage So we should check the volume of BS on the seed and time interval from BS aspiration to immersion to liquid nitrogen is optimal or not. Yeah, we have to check it. And also, if embryo survived just after warming, but degenerate or fragment after culture, so removal of cryoprotectants might be insufficient. So we should confirm whether a cell was shrunk sufficiently and the cell membrane can be observed clearly in TS. Yes, and so my answer is, so according to the degeneration type, we have to review our procedures.
Thank you, Kenji. Any inputs from Adele and Sweden?
I think Kenji has explained very well on all this troubleshooting. Yeah, very detailed.
Yeah. I think he covers everything.
Yeah, great. Yeah. So, has any of you done like a dual stimulation patients? And so, can we use that to increase the frozen oocyte pool in a short period and increasing the cumulative live birth rate? Is that doable? Like dual stim, have any of you done this?
Dual steam, yes. Dual steam meaning that after 5 days after the OPU, and then you see some of these few small follicles, then you start the steam again and collect the eggs. The main thing is to try to increase the number of eggs for either for freezing or for fertilization later on. But what we talk about, what you see in the literature is more on the quantity of number of eggs that been collected. None has mentioned about the quality of the eggs from the dual steam after the second steam. So from my experience, most of the time, those eggs that have been collected from the second steam, the steam prior after the first one, usually the quality is a bit compromised and it's not as good as those in the first collection, first steam. That is my experience. Yeah, I don't know about Adele whether you have come across this. Yeah.
Yeah, I agree with you. Most of the dual steam protocol are only for indicated cases. Mainly it's just to increase the quantity of the eggs instead of the quality. Yeah.
So yeah, due to the limited time frame, which probably in the future we can allocate maybe 1.5 hours to answer all the questions. Yeah, it's very popular. Yeah, very successful web series. And I will probably bring up 2 more questions for discussion. The first one is how to evaluate the use of new media, and such as some company. I'm not going to mention a company because that might have a commercial bias. So something like RTU or like ultra fast warming in terms of clinical effectiveness and time saving. There are some companies talking about that. And the second question, actually kind of like a wrap up, is the embryologist training for freezing and warming procedures. What's the most important things though? So the first is how to evaluate the new media, and second is how do you train and evaluate the embryologist. Adele, would you like to go first?
Yeah. For if let's say you are referring to the ready to use versus the not ready to use, it's not easy to do a comparison because it's different from other culture media like the normal embryo development culture media, which we can do sibling oocyte and then we can compare which is better. But for ready to use versus not ready to use, it's not easy to compare unless you have to stop using your previous method and then start using the new ones. So usually in our lab, we will wait for people to publish papers. So that is not easy to do because But I have tried the ready-to-use culture media, the vitrification and warming media before. Personally, I don't quite like it. It's not because of the performance is not good. It's just that the manipulation, the handling wise is not so user-friendly compared to the previous. This is my opinion. And then regarding the training, usually before we certify an embryologist to do freezing, they need to go through many rounds of simulation exercise in freezing eggs, those unwanted eggs, for example, like those not matured one. They usually we will keep those and for training. So we will usually not use blastocyst or embryo for training. We usually will only use eggs, as long the embryologist is competent enough to freeze and thaw eggs, meaning they are competent enough to freeze and thaw embryos and blastocysts. And then also we have a continuous feedback. We establish a continuous feedback loop to evaluate our staff performance, and we also regularly train, and the embryologists are regularly trained. I mean, those competent embryologists are regularly trained and updated on the latest techniques, the new equipments and protocols. Yeah.
Sweden and Kenji.
Maybe Kenji talk first.
Yes.
Yeah. So as for first question, so I'm talking about ultra fast warming. Yeah, and so this protocol can improve workflow in embryology laboratory. The conventional protocol need 10 minutes. However, novel protocol requires only 1 minute. Furthermore, so recent study reported that the pregnancy outcomes after ultra-fast warming are comparable with those of conventional one, or even higher than the conventional protocol. And they speculated that the shortened warming protocol could reduce exposure time to non-physiological temperature, resulting in good outcomes. However, the risk of over-rehydration and necrosis may outweigh this advantage, especially in poor quality embryos. So recently we performed some experiments, and we detected the increased necrosis after ultra-fast warming. Yeah, so this is published soon. Yeah. So in my opinion, I personally consider that this protocol may need some modification. And second question for training for cryopreservation.
Yes.
So in our clinic, the junior embryologist first memorize a protocol for oocyte and embryo vitrification, and they try to explain the principle of vitrification with drawing. And then they practice a procedure using discarded oocyte and embryos. And their procedures are checked by senior embryologist or lab director. And after mastering the procedure, they will take an examination using mouse embryos in our research division. They vitrified and warmed 30 mouse 2-cell stage embryos, and the blastocyst formation rate will be assessed 3 days after culture. And if developmental rate is higher than 85%, they will pass the examination and they can vitrify embryo in the clinical laboratory. So this is our training system.
As for and I think for any ready-to-use vitrification, the composition of those components are quite similar. I think the only difference is the carrier. Difference between, let's say, cryotop or some other things. So this will affect. Most important is the carrier itself affects probably the rate of freezing, rate of ultra freezing. So that is very important, because it affects ice crystallization. So it comes to composition, there's no issue, but I think the career-wise is probably the one that is more important on the successful outcome of the vitrified eggs or embryos. And as for training, like what Kenji and Adele has said, the junior embryologists will come in. We will train them using discarded eggs and embryos until we are under supervision under a senior embryologist. And then once we are comfortable with her, him, then we will maybe let them try one or two clinical embryos and then freeze and then thaw them later. And then if we give successful survival rate and pregnancy, then slowly we will let him or her take over the clinical process. But in Singapore, it's quite tough in the sense that for the junior embryologist to acquire a license to practice accreditation, she has to do 50 clinical, at least minimum 50 clinical freezing and thawing procedures, and the KPI before one of these procedures before she can get a license to practice as a clinical embryologist. So the training is very tough. So about 1.5 to 2 years for embryologists in Singapore.
So we still have 20 questions lining up. However, due to the time of the web series, we have to kind of close here. And I really appreciate all three speakers sharing their insights, experience, and provide a lot of very useful advice. And also the overwhelmingly popular questions from the audience. And I believe we'll definitely have more rounds, more web series talking about the relevant topics, so the audience can participate more and bring up more questions. And also, I would like to bring the 10th master class. I would like to promote those master classes, which you can go to the class and you have unlimited time asking the questions with the speakers. And many of us will be in some of those master classes. So the 10th master class on the cervical incompetence and the cervical circlage will be held on the 21st and 22nd of September, which is upcoming in a few days in Beijing, China. It will be a 2 days program addressing the various aspects, and also the master class will provide live surgery demonstrations and video presentations. And the next one is our embryology SIG master class. Please, the next slide. The 11th master class, we will talk about the 4 decades of PGT. It will be held in Seoul, Korea next month. It will be a 1.5 day lectures and a half-day hands-on workshop. The workshop has a very limited registration, and I would like to encourage everybody to sign up and visit Seoul, and also join us to learn and discuss with each other. The program will aim to provide a very comprehensive understanding of PGT, and as well as some of the, for example, the vitrification for the PGT samples as well, applications and implications of PGT. And also the Aspire 2025, the abstract submission has been opened, the call for abstract, and you can choose those areas to present your research, and it will be in Singapore at the Suntech Convention and Exhibition Center. Yes, please come. And yes, and I believe all of our speakers and also myself will be there, and it's a very not just the academic, but also for the embryology SIG groups, we will have the free Congress course. You can interact with others, and we get to know each others and socialize with each other. it will be a very fun and very insightful workshop as well as the main program. And I would like to thank the Aspire headquarters, the coordinators and secretaries. They put a lot of efforts organizing the web series. And thank you all for participating. And I look forward to seeing all of you in a future web series, as well as on-site master class and Aspire 2025 in Singapore.